Thank you, Rajat. Good afternoon, everybody. So, today we are going to talk about palliative care emergencies. So, by hearing this, you might be thinking, what would be the emergencies that can occur in palliative care? So, in each specialty, the emergency is decided by the nature of the illness and the urgency by which it requires treatment and the severity of the problem. So in palliative care also, we there are some situations which the palliative care community consider as emergency, and if you don't treat properly, it can lead to morbidity and mortality. So today's session will be handled by Dr. Pankaj. Dr. Pankaj has done his MD in palliative medicine from Tata Memorial Hospital, Mumbai, and presently he is working as the assistant professor in Kasturba Medical College. And he is also leading the renal supportive care at Manipal Hospital, Manipal Medical College. Welcome, Pankaj, and it's over to you.
Thank you so much, sir, for the kind introduction, and welcome all participants. I'm Dr. Pankaj. I will be talking about today about palliative care emergencies that are commonly we see in palliative care centers. I will share my screen. Can you see my screen now?
Yes, sir, we can see it.
Okay, so we'll talk about some of common emergencies that we see in palliative care setups and how we can treat those emergencies. What should be our approach in these emergencies? So it may be a bit different from common emergencies that you see in your casualty wards, or it may differ from illness to illness what you are seeing. So commonly our focus will be on emergencies that we see in oncological setups, but apart from that, some emergencies and other neurological illness or other chronic illness. So how do we define, as Sunil sir said, like these emergencies they depends on what nature of illness, how severity, and how we need to how we need to treat these things. So emergencies are those situations in which there is a threat to life or quality of life if it is not diagnosed and treated early. So sometimes it can also lead to death of patients, or can significantly deteriorate patients' quality of life for long term. So it is very important to identify these emergencies and also to treat as early as possible. So what are common concepts if when we are treating this? Yeah. What should we ask ourselves when we are seeing these patients of palliative care patients who have chronic, like limiting illness in some last few months or last few years of their life? When we are treating these patients, we should have some concept in our mind. So first is to know if your patient is at risk of any emergency. So that is means early identification. So some patients with vertebral metastasis or spine metastasis, if it is impinging into the spinal cord or very near to spinal cord, these patients may be at risk of spinal cord compression later on. Those patients who had underwent breast surgeries or MRM has been done, and they are at risk of lymphedema, or some patients who has very big mediastinal mass. These patients can be at the risk of superior vena cava obstruction. So we need to identify those patients who are at risk of coming to emergencies, and also we need to give them some plan what to do when such emergency occurs. Otherwise, it will be a state of panic for them. So it is important to identify patients at risk. Then what's the problem? What is the diagnosis of this? Can it be reversed? Can it be reversed with some interventions? And then it is very important to do that treatment. And if we are doing the reversal of symptoms, what will be the effect on patient's overall condition? So if a patient is presenting with some airway obstruction. Okay, so in tracheal obstruction, usually what's up? Treatment will be tracheostomy in those cases, but we need to see what will be the effect if we do the tracheostomy in this patient. So that judgment is will be taken after seeing the patient's condition. If patient is at end of life, we are expecting a few days or just few weeks of patient's life expectancy, then will that doing any interventions or painful intervention will be justified or not? And then what does the patient want, what patient actually want, and their caregiver wants, and could treating that condition will improve or maintain the patient's quality of life is important. So we will talk about these all concepts when we discuss each medical emergencies. Okay. Next. Okay. So based on the system involved, we have defined, we have classified those emergencies into various systems. So neurologically, that most common what we see in advanced cancer is malignant spinal cord compression. And then in patients with brain metastasis or neurological illness, we see raised intracranial tension. Delirium is a very common condition that we see in patients who are admitted or very elderly. It's a common emergency. Sometimes they come with hyperactive delirium. Status epilepticus is also very, very common. So these emergencies we will talk in detail. Then some metabolic emergency that may come with. So usually patients with hypercalcemia or hyponatremia, they may come, and if treated, if identified and treated early, it may improve their quality of life significantly. In GI, we see a malignant bowel obstruction or a small subacute bowel obstruction, and that is very common. And there are palliative approach or conservative management for these illness. And respiratory tract, you can see airway obstruction or superior vena cava obstruction, that is common. And vascular, the DVT or acute thrombopulmonary embolism. Acute pulmonary thromboembolism may be common. It's very common in patients who are receiving chemotherapies and all. Then hemorrhage. So if there are any large hemorrhage or carotid blowout, those things, how do we manage in palliative care? In renal, sometimes obstructive uropathy in patients with rectal cancer or cervical cancers may be very common. Fractures are common in patients who are elderly, osteoporotic, or those who have bone metastasis or bedbound. These can come in your emergency. And what's the most common emergency that we see is pain crisis. Patients come with very severe pain, uncontrolled pain into the ED. And that I think every one of you, if you are seeing palliative care patients, you will see many patients coming into pain crisis. Sometimes if opioids are not titrated carefully, or someone who had taken overdose of opioids may come with opioid overdose also, that we need to understand. And infections are common everywhere. So patients may come with sepsis and septic shock, or multi-organ dysfunctions. So a few of these emergencies we will talk in bit detail. Some we will just go quickly over this. So first, go to a case. Okay, so I had one lady, 46-year-old. She was diagnosed with metastatic CA. She was diagnosed with CA breast. For that, she underwent breast surgery, then adjuvant chemotherapy she received. But after that, she developed liver, bone, and nodal metastasis. For few days, she was symptomatically comfortable, but since last 1 week, she complained of lower back, and that she said that it increases on lying flat and on movement. Also, she said that pain is radiating to left lower limb since last 2 days she didn't had any power in both lower limbs. She is not able to walk. She also developed retention of urine. She is not able to pass urine, and also increased back pain. So what can be the probable diagnosis in these patients? In this patient? Okay, so yeah, Dr. Shashikala said it can be spinal cord compression, cauda equina. Okay, good. Compression of what?
Yeah, spinal cord.
Spinal compression.
Med.
Okay. Yes.
Spinal cord. Yeah.
Okay. So most common this thing is spinal cord compression or cauda equina. So that depends on which level it is involved. Okay, so commonly it depends, and it looks like she may be in a spinal cord compression because she is a CA breast, and which has been metastasized to bone, and she is having back pain, and that increased with movement or lying flat. So again, it is indicative of something wrong with spine. And now she developed neurological symptoms. So again, it can be in spinal cord compression. Okay, so we will go in with detail of malignant spinal cord compression. So and this is our normal spinal cord in figure A. And here you can see the spinal cord vertebral body and the spinal process. Okay, what happens if a patient develops any metastasis into the vertebral body, and that is impinging onto the spinal cord? There may be the compression of spinal cord itself, or maybe of the nerve roots that are coming out of it. So anything depending on what level of compression or what structure it is compressing on, it can give some symptoms, neurological symptoms in these patients. This is very common in thoracolumbar vertebrae, not very common in cervical or sacral arteries. So our spinal cord end at which level? L1 it ends, and after that there are some nerve roots that coming out of it. So if it is any metastasis till L1, that may cause spinal cord compression. Below that, it may lead to some nerve compression may be there, or even if down it there, it may cause cauda equina syndrome. What are common symptoms in these patients? So as our patient had, the most common symptom is pain, and that is the first symptom usually to come with. According to the site involved, they may complain of lower, middle, or upper back pain. It is usually progressive and it may be localized in these patients. It increases on some activity or maybe coughing or sneezing. Also, because on lying flat, it may be compressing directly over the spine. That may increases the pain. As I said, it is usually the first symptom to come before neurological signs to appear. And usually it is radicular in nature, maybe radiating downward. If we examine, these patients will have localized spine tenderness most of the time. So these patients usually say like on massage there the pain increases. The massage does not reduce the pain, but it usually increase. Okay. Uh, uh, Other neurological symptoms may be difficulty in walking, there may be motor weakness, radicular pain, bowel and bladder involvement depending on which level it is involved. Then there may be some sensory loss also. If it is involving, especially if it is involving in the dorsal vertebra, there may be some bend-like sensation at that level may be present. And then sign maybe most of the time it's a spastic paraparesis, or if it is high up into the cervical vertebrae, and these patients may have quadriparesis also. Most of the time it is UMN lesions, so it's exaggerated reflexes are there, or extensor plantars are there. So all patients who are coming with radicular pain, especially in lower limb, you must do the reflexes and plantars in these patients. Sensory level, if patient is complaining that there are loss of sensation or unequal sensation in legs, then you should identify what sensory level is there or which dermatome is involved. Then check for bowel or bladder. Most of the time it's a urinary retention they have. Sometimes they may have postural hypotension or autonomic changes in the blood pressure also. So how do we, if we have a suspicion of spinal cord compression, and then how do we diagnose it? How we will approach? So the gold standard is MRI. MRI will show you where exactly the compression is. But sometimes patients may not be affordable for MRI. In that case, we can do the X-ray also, or sometimes CT scan can also reveal the level of compression. But if you want to know exactly how much involvement of spinal cord is there, or we want more specificity, then MRI would be gold standard. Okay. Then going into the pathophysiology. So what happens when there are any compression of spinal cord? So usually there is a venous stasis happens. Venous stasis means there is the capillaries and there are blood vessels are compressed, and that cause more blood to stay there. That releases more of inflammatory markers, interleukins and prostaglandins are released there, and that causes vasogenic edema in these patients. Edema, again, there's already a compression, and a surrounding edema will increase that compressive effect, the pressure effect on a spinal cord, and that will lead to neurological deficit in these patients. And because of edema, there will be ischemia, and ischemia will also will lead to death of neurological tissues, and again the neurological deficit will occur in these patients. Also, ischemia releases some amino acid signals that causes more cytotoxic anemia, and that may cytotoxic edema may lead to the permanent damage. So based on this pathophysiology only, we can attempt our treatment. So in treatment, the first and foremost treatment is bed rest. We do not want the injury to increase. So we tell the patient to not to move and have complete bed rest. While shifting the patient on stretcher or over the bed, we need to be very careful in these patients that we do not increase the injury to spinal cord, especially if there are lytic metastasis or fractures, virtual fractures are there. We need to be very careful in these patients. Then next, most important is steroids. So using steroids, especially dexamethasone, in higher dose may improve the outcome in spinal cord compression. So steroids, if started within 24 hours of developing spinal cord compression, have a good effect, and it need to be continued till patients receive some definitive treatment. So what are the definitive treatment in these patients? To the next slides, okay. So high dose DEXA is around 24 to 40 mg per day. We usually give 16 mg stat dose IV, and then 8 mg 3 times a day, and avoiding the night doses of steroids. So usually we can give 8 mg early morning, then in afternoon, then in evening at around 4 o'clock, maybe the last dose to be given. So that's how around 24 mg to 40 mg per day of preferably IV dexamethasone should be given. How will it work? It reduces the vasogenic edema and the inflammation there, and it may relieve from the pressure effect there. Okay. Then we need to give them the adequate pain relief. So we can use some NSAIDs, that is again anti-inflammatory, or if pain is very severe, opioids can be considered. Because it's a neuropathic pain and bone pain is involved, so adjuvants can be added like pregabalin or amitriptyline. Gabapentin can be given. If these patients has bowel or bladder involved, then managing the bowel, sometimes these patients may require some stool softener, or sometimes manual evacuation may also be required if a patient has, especially if it is a long-term spinal cord compression. Then coming to the definitive treatment, and then radiotherapy in most of malignant spinal cord compression is the treatment of choice. So usually it should be started within 24 hours or maybe up to 72 hours we need to start. The fractionation may be different from different illness, but usually it's 5 fraction or 10 fraction, or sometimes single fraction is also given to these patients. And this is more important in those patients who have who were ambulatory before diagnosis of spinal cord compression. Yeah. In those patients, RT should become considered for. Some patients may be candidate for surgery also. So surgery is recommended in those cases where there is progressive neurological illness, or there are vertebral column instabilities there. Some patients who have radio-resistant tumors may be considered for surgery, but usually it is when there are single point or lesser number of compressions are there, we can consider. Chemotherapy, usually it is not very common to give in spinal cord compression, but if it is because of lymphomas or germ cell tumors that melts with chemotherapy, it can be considered in those patients. Then how do we prognosticate in these patients? So prognostication, first and most important prognostic factor is ambulatory status. And was the patient ambulatory before diagnosis of spinal cord compression or not? And time from development of neurological symptoms to the treatment. That may be steroids or radiotherapy or surgeries. That is important. Then how the cancer behave itself. So if it's a radio or chemosensitive tumor, myeloma, prostate or breast cancer, these have a good survival in these patients. It's also, it may respond well to the treatment. Uh, so that was about the spinal cord compression. Before moving to any other topic, if there are any doubts, we can discuss here. Am I going too fast?
Pankaj, can we take the questions last? I think that would be better.
Yeah, no problem, sir. Yeah.
Okay. You are not fast. Participants are saying no.
Okay.
Okay.
Okay. So next neurological illness is raised intracranial pressure. So raised ICP that we talk about. So it is common in those patients who have brain metastasis or if there is any neoplastic meningitis or primary brain tumors they have. What happens? We know that brain is a closed cavity. There is nothing, no scope of expansion. So if there are any lesion in the brain, if any expansion occurs, the volume cannot increase and the pressure will increase. If pressure increase, it will again will cause either pressure on the other neuron tissues or into the ventricles or over the vessels and all. So it may lead to severe symptoms. So most common symptom in patients with raised ICP is headache. They will complain of a headache. It may be frontal or global headache. Altered sensorium or vomiting is other common symptoms. So projectile vomiting in these patients are very common. Many patients, they come with altered sensorium like drowsiness or restlessness they may present with. These patients may also come with seizures or some focal neurological deficit also. That is more common in those patients who had brain metastasis or primary neurological tumors are if it is present. Usually, and the onset is acute and it progresses over the days and it has a fluctuating course also. And what are the common malignancies that metastasized to the brain? If we see, most common is lung and then breast and other malignancies can be there, but lung and breast are the most common malignancies. Melanoma we don't see much here in our country. So the treatment in raised ICP, again, wherever you see there are increased pressure, we usually use the steroids. So again, anti-edema measures, we start a high dose of steroids. So usually starting dose 16 to 24 mg. And it can be given for 3 to 4 days or until WBRT, the radiation, that is the definitive treatment, that is started. So we give 4 mg thrice a day or 8 mg thrice a day, depending on the requirement. And then once radiation is started, we can slowly taper the steroid. Many patients, especially those who have intracranial malignancies, gliomas and all, they require steroids to be continued for quite a long time. That may be a smaller dose of steroids may be required, like 4 mg or 2 mg to reduce their symptoms. Then other things that we can give is mannitol and IV, that is usually for 3 days, and glycerol can be given in, after mannitol, or those patients who are at home. If we can't give IV mannitol, then this salt can be considered. When we are giving mannitol, we need to monitor BP and keep adequate hydration. Also, in patients who have a hyponatremia, we should be careful about these things. Then analgesics. So analgesics, usually NSAIDs or paracetamol is the drug of choice for this. We should be a bit careful when we are using opioids in raised ICP, because the adverse effect of opioids may be higher in raised intracranial pressure. Sometimes opioids can also increase the ICP. So we need to be more careful about opioids. But yeah, if it is indicated, you can start with a lower dose and then see. In these patients, if seizures are there, then we need to start phenytoin or valproate levetiracetam we can use. Prophylactically, there are not much evidences, but we see many times who have brain metastasis, they are on prophylactic dose of levetiracetam or phenytoin that can be used. Then definitive treatment usually whole brain radiotherapy if there are multiple metastases. Sometimes we can use SBRT also if there are very few mets or single metastasis there. Sometimes if it is oligometastasis, they are not much metastasis. Then they do the craniotomy and surgical excision of brain mets can be done. But if we see in palliative setups, most palliative care setup, we most of the time see patients with multiple mets, and at that time, whole brain RT is the preferred treatment. When we should not give whole brain RT is when patients performance status is very poor. So like Karnofsky performance scale, if it is less than 60, we should avoid many interventions, or even WBRT may not be helpful in these patients. Then coming to third emergency, that is status epilepticus. How do we define it? So it is any seizures that is more than 5 minutes of continuous seizures, or more than 2 seizures with incomplete recovery of consciousness, if it is there. There may be a number of causes of status epilepticus, but most commonly it is because of there are metastasis or primary brain tumor are there. Sometimes it is because of hypoxia or some infection. There are metabolic changes, hyponatremia, hypercalcemia. These all things can also be cause seizures activity. How do we treat these patients? So first thing, again, we need to identify those patients who are at risk, and those patients who have brain metastasis, uncontrolled sugars or dyslexia is there. These patients, we need to be more careful. When we get a patients with a status epilepticus, we need to secure airway, breathing and circulation. Airway, that depends on again if there are how's the prognosis of the patients. Otherwise, doing intubations may not be helpful. At home setting, giving nasal midazolam may be very helpful. So nowadays, you might know that there are Midasep comes, that is nasal spray of midazolam are available. Sometimes and these patients, especially in home care, we can give buccal midazolam, which can just open a ampule of midazolam and keep sublingually. That may help. Or subcutaneously or IV midazolam can be given if patient is in hospice or hospital setups. Giving thiamine or dextrose, sometimes it helps. Then loading dose of phenytoin is important. So we give 15 mg per kg of loading dose of phenytoin and to control status epilepticus. If phenytoin is not helping, then phenobarbital or some other anesthetic agents can be used if with these midazolam and phenytoin if it is not controlled. So that was about the common neurological illness. Now we are coming to dyselectrolytemia. Two common dyselectrolytemias we will discuss here. One is hypercalcemia. Hypercalcemia is when corrected calcium is more than 10. Okay. Commonly, it is seen in lung cancer, also in any cancer where the bone is involved. Okay, so in breast, myeloma, lymphomas, or head and neck cancers, especially when it is involving the mandible and all. Esophagus we see very commonly. So when do we suspect hypercalcemia? In those patients where there is irritability or lethargy, delirium, in these all patients we need to do. There is some disturbance in between. Mic off, please. Yeah, thank you. Yeah, so in those patients who are coming with delirium or irritability or altered sensorium, we need to do all electrolytes we need to see, including calcium also. Vomiting, and that is persistent severe vomiting, is very common in those patients who looks very dehydrated or less urine output with vomiting. We must see calcium level in those patients. If we had any ECG and if there are any changes of hypercalcemia, then again we need to look for calcium level in those patients. How do we treat hypercalcemia in these patients? So it depends on how severe is hypercalcemia. So we calculate corrected calcium level. If it is more than 12, that means that it's a moderate to severe hypercalcemia, and that need patient to be admitted under in a palliative care center or in as a IP. If it is less than 12, then we can manage at a home basis also with adequate oral hydration or with diuretics. Okay, so if it is less than 12, we just can give good hydration, ask the family to take ask the patient to take good fluid, at least 4 liters per day, and diuretics if patient has any heart failure signs or signs of fluid overload. But if it is more than 12, then we admit the patient, we give IV hydration around 3 to 4 liters over 24 hours. If those patients who has heart failure signs or there is raised JVP, then furosemide may be given. So usually if we are giving so much of hydration, we give around 40 to 60 mg per day of furosemide. Then for immediate correction of hypercalcemia, subcutaneous calcitonin can be given, and that immediately will reduce the calcium level. So 200 international units subcutaneously TID it can be given. And also bisphosphonate. Bisphosphonates usually takes around a day or two to work. So we can give zoledronate 4 mg if renal functions are normal. It can be given. But remember, both of the treatments are costly, and we should justify the use of calcitonin and bisphosphonate in these patients. We should monitor input-output chart as we correct the calcium. Usually the output improves, and that we need to monitor about. Usually it takes around 3 to 5 days for normalization, and after after around 1 or 2 weeks, we need to repeat again, because if we had given bisphosphonate or calcitonin, there are chances that patient may go into hypocalcemia also, or in some patients, again, the hypercalcemia may reoccur. So we need to check it again after 1 or 2 weeks of correction. Why is it important to treat hypercalcemia? Because it's a life-limiting condition. Many times patients comes with calcium level of 14, 15, 16, and that can cause sudden cardiac arrest. So that and that is important that we identify. Other than that, it can cause severe symptoms also, like fatigue, irritability, or vomiting. These symptoms, and if we can correct those things, patients may improve. Similarly, hyponatremia is another common dyselectrolytemia. It is being classified into type 1, type 2, or type 3. So type 1 is hypervolumic, where there is a lot of extracellular fluids are there. It is usually seen in hypoalbuminemia in patients with liver cirrhosis or congestive cardiac failure, where there is a lot of extracellular fluid, and because of that, there the dilution, because of dilution, that leads to hyponatremia. In hypovolumic, that is usually acute after dehydration, diarrhea, or vomiting, where there's a lot more of concentration, and that because of the sodium loss, it leads to a hypovolumic hyponatremia. And third, that is most common, is where neither there is overhydration nor underhydration. The hydration level is normal. It is very commonly seen in patients who are having chronic life-limiting illness, especially in lung cancer. It is very common. Neurological illnesses it's quite common, and so we need to see. What are the common symptoms of hyponatremia? It's anorexia, nausea, malaise, or irritability. It's very common. Sometimes these patients may also come with confusional state, muscle pain, or fatigability. And sometimes they may present with seizures or coma also. So we check for calcium level. If calcium level is less than 135, that is called as hyponatremia. But usually that is not a worry until unless patient is having symptomatic. So if sodium level goes below 120 or 125, that is called as severe hyponatremia. And at that time, many times symptoms are present. So our main concern is when the patient is symptomatic and having severe hyponatremia, that is more than 120 or 125. If it is more than that, we can just we can correct that thing. So if we are considering SIADH, where there is neither overhydration or loss of sodium, then we can give just extra salt in those patients, and that may be sufficient in those patients. But if it is less than 120, that means that we need to admit the patient and correct it more aggressively. So what are the common approaches to treat SIADH? So one is reducing the water intake. We tell the patient to reduce it to 1.5 liter per day, not more than that. We can give extra salt or saline, concentrated saline, so that is 3% NS can be given. If there are any other cause for SIADH, like infections are there, then that need to be corrected. In some patients who have persistent hyponatremia, then fludrocortisone or tolvaptans can be used. Okay, so when we are correcting, we need to be mindful that we should not correct it too fast, unlike other electrolyte imbalances. For sodium, we need to be very careful. So our rate should be around 4 to 6 milliequivalent per day to avoid the risk of pontine demyelination. Previously, we used to learn that the rate should be around 10 to 12, but nowadays the recommendations are to go more safer. And that too, they suggest to correct it by 4 milliequivalent, maybe over 3 to 4 hour, and see if the patient is having a clinical improvement with improvement of sodium by 4 milliequivalent, then that says that this present clinical condition was because of hyponatremia. If the clinical condition is not increasing, that then we should think of some other causes also. Okay, so previously there was an approach of identifying the sodium deficit, and then according to the sodium deficit and we need to give the 3% NS over 24 hour and all. But nowadays they suggest to give 3% NS at around 0.5 to 1 ml per kg per hour, and then after giving 100 ml of NS, then we can monitor sodium again. So maybe more frequent monitoring of sodium rather than waiting for 1 day and then checking it. So that is usually recommended. So usually we give 100 ml NS of 3% NS over 2 hours, and then we repeat sodium again. And if it increases the sodium by 4 ml equivalent, we stop at that point of time, and we do not give 3% again for that day. Okay, so that was about the distal electrolytemia. We'll talk about other emergencies in a bit short. Okay, so then comes the acute airway obstruction. So acute airway obstruction usually present as stridor or shortness of breath. Then in these patients, we need to treat the patients with oxygen. Again, high dose of steroids can be given. If patient is in too much of distress, then opioids or benzodiazepines can also be given at that point of time in palliative setting. Then we need to select whether doing tracheostomy will be helpful or not. If we expect the patient's prognosis is good, or patients have months to years to live, and that also with good quality of life, then considering a tracheostomy may be appropriate, especially if it is at a higher level. Otherwise, if the prognosis is very short, then we need to focus more on the to relieve the patient's distress. Okay, so sometimes giving adequate sedation or medications to relieve breathlessness can be given at that point of time. Then comes the SVC obstruction. SVC obstruction usually comes into the blood vessel emergencies. So if there are any mediastinal tumors, or if there are any large thrombus that went into superior vena cava, and that is impairing the return blood flow into the heart, that can lead to features of superior vena cava obstruction. Most commonly, it is seen in patients with lung cancer or lymphomas, which has large intestinal lymph nodes. So what will be the common symptoms in these patients? First and all, patients may come with dyspnea or edema in upper extremities, and facial edema may be there. These patients may have conjunctival injections, swollen tongue may be there, and red faces may be present in these patients. Also, they may present with headache and blurring of vision due to more of cerebral edema. Sometimes shortness of breath is maybe because of the tracheal edema in these patients. Also, these patients will have dilated veins, superficial veins, or JVP may be elevated in these patients. If it is a chronic SVC obstructions, they may develop some collaterals that we can see the flow of blood through the collaterals. Maybe present. So in these patients, what will be the treatment? So again, treatment is steroids, high dose steroids need to be given in these patients. If it is chemosensitive, like lymphomas and all, chemotherapy need to be started as early as possible. Otherwise, like in lung cancers or any other metastasis from breast cancers and all, we can consider for palliative radiotherapy can be considered. Furosemide doesn't have much role, although some books had mentioned for furosemide, but it doesn't have much role as far as evidence are considered. Then if it is the intravenous, if it is in the spinal cord, in the SVC, then we can consider low molecular weight heparins, or SVC stenting can be considered in those patients. Although most of the time it is extrinsic compression, it's compression because of the mediastinal mass in these patients. Then hemorrhage is quite common in these patients. So it can be because of treatment that may cause mucositis or thrombocytopenia, less platelets. Sometimes patients are on anticoagulant or NSAIDs that can increase the bleeding tendency. Patients with advanced liver disease, their coagulation factors are affected, and that may lead to bleeding and diastasis. Sometimes infections and advanced malignancy itself can lead to DIC conditions, and that may lead to bleeding. In palliative care, we are more worried about the large bleeding, major bleeding, if it happens, especially in head and neck cancers that are there. So in head and neck cancers, which has a ulcerative wound, and these, especially over the neck, they are at risk of carotid blowout, or any large bleeding because of involvement of our large blood vessels. What happened at that time? There are large bleeding occurs, and we may not have time to control that bleed. So that is called as terminal hemorrhage, and this may be very, very traumatic for the patient and family members, very distressing. So what we do in that case, we can identify those patients who are at risk of such bleeding. If that bleeding occurs, what all we can provide them some kits if that bleeding happens. Okay, so that may contain some dark towels or even dark saris or any cloth, so that it will prevent the sight of blood, the red blood everywhere, and that will absorb the blood. We can keep some compression with that. At that time, we need to give some sedation to the patient also, that so that patient is not restless, giving some midazolam or opioids also that is available, that can be given, and sometimes ketamine may be given. Such hemorrhage, we may not be, as a physician, we may not be able to control, but being there will make a difference at such distressing measures, and it will give some assurance to the patients and family members out And that was about the large hemorrhage. In smaller hemorrhage, we can give tranexamic acid in 500 mg to 1000 mg thrice a day. Vitamin K, if there are coagulation factor deficiencies or and warfarin toxicities or in patients with liver diseases. FFP and RDP if there are less platelets are there, or FFP if there is acquired DIC is present. PPI and sucralfates are important in patients with GI malignancies, and hemostatic radiotherapy if it is because of the cancer bleeding is there, then hemostatic radiotherapy may be helpful. Then I will come to acute pain crisis. I think and that is usually it is covered when we talk about about pain management. So if any patients who are coming with severe uncontrolled pain that is causing severe distress or having a pain at any point of time more than 7, that will be called as uh, uh, acute pain crisis. So at that point of time, we need to give opioid titration in these patients. So usually preferred drug is morphine, and that can be given IV or subcutaneously. The doses are different in patients who are opioid naive or opioid on opioids. So if patients is already on opioid, we usually calculate how much breakthrough dose need to be given. It is usually 1/6 to 1/10 of oral per day requirement, and then changing it to IV. If a patient is opioid naive, that means patient was not on any opioids earlier, then we can start with 2 mg of subcutaneous morphine and giving every 5 to 10 minutes till the adequate pain relief is there. Okay. Then comes the opioid toxicity. So in case a patient is coming with severe opioid toxicity, either because it was not used in proper supervision, or patient has consumed too many of tablets, or sometimes if it is given by mistake, given in higher dose. And then there are chances of opioid toxicity may be there. So what are the common signs of opioid toxicity? The patients coming with the history of taking inappropriate dose of opioids. I'm telling here inappropriate dose because usually when we are using it at the proper way, the opioids are not, they do not present usually with toxicity. Okay, so these patients are coming with too much of sedation, confusion, delirium, sometimes hallucinations. Uh, this is the usual history in these patients. Then they may have pinpoint pupil or myoclonic jerks, usually in upper limbs, maybe there. There is slowing of cardiorespiratory systems, so their respiratory rate or blood pressure will be low, and these can come with seizures or may develop cardiorespiratory arrest also. So what is the management of opioid toxicity? So usually managing airway, breathing and circulation, then starting naloxone. So naloxone is indicated if respiratory rate is less than 8 per minute in a patient who took opioids, or respiratory rate between 10 to 12, but he is drowsy or cyanosed, then we need to give. Or in patients whom respiratory rate is less than 12, but they are drowsy and their saturation is less than 90, in that case, we need to give naloxone. How to calculate the dose? So usually we dilute 0.4 mg of naloxone in 9 total 10 ml syringe, and we give 0.5 ml of solution every 2 minutes until unless patient's respiratory rate or the drowsiness recovers. So that is about the opioid toxicity. But most important thing is careful. We should titrate opioids carefully and give it in mode of supervised manner. So that was in brief about common emergencies that we see in palliative care setups. I think we can have some discussion for some time on this if someone have any doubt.
Thank you, Pankaj. I see there is a one question in the chat box, and Dr. Girija, she's asking how to adjust the dose of analgesics during hyponatremia and hypercalcemia.
Okay. So usually it is there's nothing to do with opioid doses like for the pain management with dyselectrolytemia. We can safely titrate the medications. In hypercalcemia, sometimes patients may come with acute kidney injuries also. So their creatinine may be more high or maybe dehydrated. So at that point of time, we should not use any CIDs or those opioids like morphine that is that is excreted through kidney. At that point of time only we should avoid, but otherwise we can safely use these medications. So we need to go through our pain management strategies, and according to WHO step ladder we can continue the pain medications in these patients, I think.
Pankaj, I think why she was asking that question, probably because hyponatremia patient in confusion and sometimes too drowsy. So
Okay.
that might be the concern, I think.
Okay. Yeah. So yeah, that's true. That if in dyselectrolytemia patients may have altered sensorium, and that may change our and the pain reporting, or also we are sometimes worried that the opioids should not make him more drowsy. But that depends on how the patient's pain was before this this acute emergency, and also was opioid causing too much of drowsiness and all. So if it was not the case, then we can continue same doses, or also even sometimes we can increase the dose. We need to continue, we need to correct the dyselectrolytemia in these patients. And then we can see how is the patient's improvement, and then we can go up for pain management. But we should not stop opioid medications if we have diagnosed that this drowsiness or irrelevant behavior is because of opioids. Then we should not stop opioids at that point of time.
What is the mechanism of action of steroids in hypercalcemia?
Mechanism of action of
Steroids in hypercalcemia, how it decreases
Okay.
hypercalcemia.
Yeah. So, usually, like nowadays, most of the recommendations are not in very favor of steroids, using steroids in hypercalcemia. I think it was written in my slide also, but usually it is not used in hypercalcemia nowadays, except in cases of lymphomas. Lymphomas, it is used because for lymphoma or leukemia that responds with steroids. That's why hypercalcemia is also reduces with steroids. But otherwise, in solid tumors, it is not recommended nowadays. In most of the guidelines, steroids are not recommended.
Yeah, just want to add, Pankaj.
Yes.
So steroids inhibit 1-alpha hydroxylase conversion of vitamin calcidiol into 125 dehydroxyl vitamin D. So it decreases the intestinal absorption. So that's how steroids decreases hypercalcemia. But the problem is that it will take a few days to have its proper action. And what is tolvaptan? Uh,
Okay.
and how
12
does it help in hyperlipidemia?
Yeah, 12-leptins are the newer drugs that works on ectopirin receptors. Through the ectopirins, usually it is used in those refractory hyponatremia that are not corrected with fluid restrictions or extra sodium that we had given either orally or and through 3% NS. In that case, 12-leptins are used. Usually, what most of guidelines suggest are this should be kept only in refractory cases, and it should not be given more than a month. Start with smallest dose, so maybe that comes as 15 mg. We can start with half dose and then going up on 15 mg. But and it should be avoided in those patients who are having cirrhosis of liver. In those patients, it should be avoided. So tolvaptans usually like it's kind of vaptans that works through the ectopirin receptors.
So any more questions?
Okay. Yeah.
So Dr. Pankaj talked about many emergencies that come across usually in palliative care. So all of them are important, and if you miss, that can lead to morbidity and mortality. So if you miss spinal cord compression, then that is going to create problems. Uh, so the prognosis of spinal cord compression is actually if a patient is having ambulatory status before radiotherapy, then probably the patient has a good prognosis. So we should not miss, and the patient may not tell you that I have weakness of lower limbs. They may even tell you that I am unable to lift my limb. I am feeling heavy. My limbs are heavy. Things like that. So we should be actually looking at this very carefully, and we have to interpret it properly. So I think we can move on to a patient story, which will be presented by Dr. Molly Thomas. Dr. Molly, it's over to you.
Okay, thank you, sir. Good afternoon, all. Our patient for today is a 32-year-old male who was diagnosed with traumatic paraplegia in 2018, and he developed pressure ulcers over the right greater trochanter, which had a stage 3 ulcer, and a stage 4 ulcer over right ischial tuberosity. Next slide, please. So what happened was in July 23rd last year, he developed a sudden onset of severe pain abdomen since 2 days, constipation since 2 days, and high-grade fever also since 2 days. But there was no vomiting. And also that the day of admission, he had a sudden onset of irrelevant talk that day morning. Next slide. So the history of the illness is like this. In 2018, he was an active young man, and while he was doing his work of unloading load from a truck, he fell down and he sustained a fracture of the T12 vertebra. And immediately after that incident, he was rushed to the hospital. and the spine surgery was done to stabilize his spine. But the tragedy was that he had developed traumatic paraplegia because of that incident. And over the next ensuing months, he developed multiple pressure ulcers, as was mentioned earlier, over the right greater trochanter and the right ischial tuberosity. And to add to that, he used to have recurrent urinary tract infection because of the catheter that was put inside. And he was referred to our hospital last year in the month of July, when he had these multiple pressure ulcers, which were very deeply infected. They were quite badly infected, so much so that even the bone could be seen in one particular area. And so he was admitted in our hospital on the 18th of July for cleaning of the ulcer for debridement, and he was admitted. Debridement was done, pus culture was sent, and antibiotics were started accordingly. And on the third day, since everything was going well, he was discharged. But the fifth day following the discharge, he developed those symptoms that was mentioned above, the sudden loss of consciousness and irrelevant talk, and he was rushed back to the emergency department on the third day following discharge. That means the fifth day following the ulcer debridement. Next slide, please. So on examination in the emergency department, when he was brought, he had a high-grade fever, 102.9, tachycardia, and he had very low BP, 90/50. He had pallor. He was disoriented, dehydrated, had a toxic appearance. There was a doubt whether he had neck stiffness. His abdomen was rigid, and there was epigastric tenderness. The ulcers over the ischial tuberosity and the greater trochanter were looking healthy because it was the debridement was done a few days earlier. So the diagnosis that we were thinking of at that point of time was, is he in sepsis, or has he got an acute abdomen? So next slide, please. So the investigations were sent, and the total count was normal, but what was significant was he had very low hemoglobin, and most of the other parameters were normal, except for a low albumin as well. X-ray abdomen was normal. X-ray chest was also normal. All other investigations for fever was also normal. Thinking of the neck stiffness and LP was done, but unfortunately that didn't reveal anything. So on a provisional diagnosis of sepsis, we admitted him into the ICU and we started treating him. The first blood culture report came out as sterile, but then the repeat blood culture showed that he had a septicemia with enterococcus. Next slide, please. So he was treated in the ICU, of course, with IV fluids and broad spectrum antibiotics initially, injection peptides, and then changed according to the culture report. We had the pus culture showed E. coli, both E. coli as well as enterococcus. The urine culture showed E. coli and enterococcus, and the blood culture, as was mentioned earlier, grew enterococcus. So we saw that he was really in very severe sepsis, and so with the antibiotics he started improving. But after a week or so, he again started having fever in the ICU, and a repeat chest X-ray showed that he had developed bilateral lower lobe pneumonia, and antibiotics were started for that, and he gradually improved, and his fever also started coming down, and his mental status also improved, and he was slowly shifted to the ward, and then from the ward he was discharged after a prolonged stay, almost a month stay in the hospital. Next slide, please. So the psychosocial background to this man and his family is that he has a wife and 2 children and an elderly mother who's staying with him. And now, since after the tragic accident that he had, he has now been confined to the bed. He's not able to sit because of the pressure ulcers. He was because he is now dependent on others. He was disowned by his family. His relatives were not willing to come and take care of him when he was admitted in the hospital. His sister initially gave some financial help, but then after that, they all left, and no relatives were seen around to help him. So his bill was partially covered by the Ayushman, and the rest was written off by the hospital. And since no one was there to help him, it was our own staff that provided the food for him and his family during his stay in the hospital. But one thing good was that his wife was very caring and loving, and she rose up to the occasion to take care of him, going all the way. But now, going back to the home, he understands that his daily care is a burden on his wife, and he has two small children, less than 5 years old, whose future is now very bleak. He doesn't have a proper ration card. He had one made, but that had a lot of issues. He was not able to get the ration, and he's now depending on his mother's ration card to get the monthly rations that he needs. And to add to it all, that he doesn't have a toilet in his house, and he had approached the authorities for that, but that is taking a long time to materialize. So he feels totally abandoned by society, and as well as by his relatives. Of course, his wife is there beside him, which is the silver line in the cloud. Next slide, please. And now, currently, he's after having survived that sepsis, he is now back at home with still having the stage 4 pressure ulcer and stage 3 pressure ulcer on regular saline dressings, and with physio. And he doesn't have a catheter now. He self voids in short period of time. Next slide, please. So the main concerns for this family or this man at this point of time is the large pressure ulcer, multiple, which drove him to the point of that emergency that he had. That is one concern, and now he is having pain in the hip joints, which I think is because of the immobilization. He had an air mattress which was provided, but that got damaged. And also in the villages, there is no proper electricity to keep the air mattress going. And as I mentioned, the need for the daily provisions, need for a toilet, and a vocational rehabilitation whenever he is able to sit up. And definitely, since his wife is healthy, whether a job for a wife is a possibility or not is what he's thinking. Next slide, please. So to summarize, we have a 33-year-old man who had a diagnosis of traumatic paraplegia 3 years back. Now having multiple pressure sores of stage 3 and 4, with an episode of septic shock requiring ICU admission and prolonged hospital stay. And now back at home with just a regular dressing of the ulcer, but which definitely would not heal without a surgical intervention like a myocutaneous flap surgery. Next slide, please. So the concerns or the points that I would like to discuss in this time was that what could have been done to prevent him from developing this emergency that he had? And secondly, what can we do so that he will not have a similar experience again? Which is almost a same thing. And lastly, what can we do to relieve his feelings of abandonment? I would like to hear from the group. Thank you.
Thank you, Dr. Modi. It's a very good patient story. So I would like to ask the group what are your opinions regarding these questions? How can we prevent further episodes of the infection in this patient? He had a infected pressure sore as well as urinary tract infection. So how can we prevent those two things in this patient? Okay, Dr. Angela says regular home care for the sores. Was the hemoglobin correct? That's a question from Dr. Sheila.
Yes, I had mentioned that he was given multiple blood transfusions while he was in the ICU and in the ward.
Okay.
Yes.
Okay. Dr. Angela also says continuous position change to prevent further sores. Anything else? Why was the perforation or pancreatitis was considered as a cause? That's a question from Dr. Chadan.
That is mainly because his abdomen was rigid and he was having constipation as well. So we were thinking whether there would be any intestinal, perforation, which is
Yeah.
yeah.
So the uh, 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 Dr. Shanti says better nutrition, proper physiotherapy, improvement of general health. Counsel the caregiver and educate them about techniques of wound management. Dr. Sheila says regular self-voiding to prevent further UTI and prevent constipation. Okay, Pankaj, do you want to take this question?
It's a very interesting case, and I'm happy to see that you have gone beyond only the physical management of such patients who was in ICU for a longer time and then was hospitalized for quite a time. And as we see that there are a lot of psychosocial issues in these patients, and these needs a continued support. And I hope with palliative care training, you will be able to manage these patients more holistically. So very good case to discuss about. A few things that you had told, and even your hospital had supported him a lot. Your concerns, I think that was mentioned in concern, that about the rehabilitations and also for some job for wife, that that is very important to if we can involve in the social worker teams or the volunteers team, that may bring down the social distress that the family has. Okay, so that was about the case. Okay, so about the physical symptoms, like he had came with the sepsis, severe sepsis that he developed. So it's very common in patients who are on bed for very long time. And if the proper perineal hygiene or bowel bladder hygiene is not kept, these patients may they are at risk of having infections, and with immunocompromised state, they may develop severe sepsis also. So regular I think now patients had control of voiding also, so maybe a good perineal hygiene can be advised for a regular bed sore care that need to be taught to the family members, patient's wife, and also adequate home visits by the nurses or palliative care team that may see how on the patient's bed care has been taken care of, and also to teach them the bed care. Uh, Maybe the only air mattress may not be required if they don't have air electricity around the clock. Even using the water bed may be helpful for them. Or most important is changing the position in these patients, so the patient doesn't have a pressure on one area only, maybe very important. So teaching those all things, we may not be able to completely prevent all such episodes or coming into developing these emergencies, but we can prevent a lot with proper perineal hygiene, I think, and training them good bowel bladder habits and prevention of such grade 4, grade 5 bread sores in these patients. I think Dr. Sunil, you can add anything if
Yeah,
I missed. Yeah.
thank you, Pankaj. So I think uh, there are a few things that we need to teach the wife, who is the main caregiver. So regarding pressure sore, as everybody told that we need frequent position changes that needs to be done, and patients who has a pressure sore need higher amount of protein. So it would be better to add more proteins into the food, maybe like egg white and pulses, etc. That we need to tell them. Then a regular wound inspection by the wife, and you have to also teach her the signs of infection. What will the wound look like if it has an infection? And the proper cleaning and dressing. Uh, so how to, if normal saline is not available, how can we dress, clean the wound with homemade saline? So those need to be told the patient. And after each bowel movement, we have to actually clean the wound. So it would be better if they can find out a particular time during which the patient passes the motion, and then he gets a bath followed by wound dressing. Then regarding UTI, we have to teach the caregiver regarding the catheter care. So how to wash the tubings or the catheter after bowel movement, and actually the it's a closed system. The bag and the catheter, once it is fixed, it is a closed system. So some of the caregivers may open the system and wash the bag, which is not advisable, which can introduce more infection. And constipation is something which we have to manage properly, because if a patient is constipated, there is more chance of getting patient urinary tract infection. So management of constipation is also important. Then regarding abandonment, so how can we do something to help him? So maybe already told that if we can provide home care, that would be good. And if there is a volunteer who can support the patient, then he will be feeling better, because somebody from that community itself going to the patient and seeing him frequently is will make him feel good. So he will feel that he's supported. And if we can also help him. What was his previous job? Uh,
He was I think truck driver.
Truck driver. Okay. So maybe he is paraplegic. He will be yeah.
So like
He is able
yeah.
to use his upper limbs. So maybe if you can teach them something like maybe umbrella making or something like that using the upper limbs, that will also help him to earn something, and it will give him some confidence. Uh, so these are few things that I the volunteer support, home care, and the rehabilitation for him and his wife. Wife will not be able to go out, leaving him alone. So both of them can work together if that is possible. And another thing I want to ask is patient. Dr. Molly told that patient is self-voiding, but she also told that, or I understand that it is very frequent. Is it true, Dr. Molly?
Yes, yes.
How frequently?
Frequently he
Any idea?
he I think it's 1 to 2 hours.
Okay. So I don't know. Actually, we have to assess the bladder for post-vital urine. Because if the patient has a neurogenic bladder, then there will be patient will be having a big bladder and will be urinating very frequently. And that may not be patient may not be knowing that it occurs, but he is passing. That's all. So we have to assess the blood post-vital urine after urination, and if there is a good amount of residual urine more than about 150 ml, then we have to actually advise him to do catheterization, either continuous bolus catheter or self intermittent catheterization. Otherwise, the post-vital urine will cause more infections.
Infection.
So
Yeah.
that's also another aspect that we have to see.
Yes. Thank
So
you.
these are
Yeah.
some points such which I would like to. Yeah. So anybody else
Thank you very
want
much,
to
sir.
add anything more?
This patient is actually quite far from our hospital, totally
Yeah.
another district. So I tried to get in touch with another hospital which is closer, which is not a COVID hospital, and got in
Okay.
touch with a surgeon whether he could arrange for a surgery so that because it's a deep pressure sore, it will not
Yeah.
heal by the saline dressing alone. So so we are just organizing that for him now.
Yeah.
Because so I talked with the surgeon there to find out if it's possible, and it looks like it can be done in within a few months. So
Okay.
that is something that hopefully can happen for this
Yeah.
man. And if it heals, then we can go on to the vocational
Yeah.
rehabilitation,
Yeah.
like how Dr. Sunil suggested. Yeah.
Okay.
Yeah.
Yeah. Education of children, that's very important. And Dr. Sheila says the patient is not able to sit down. So will he be able to make umbrella? Yes, Dr. Sheila. We have a patient who is not one patient. I think more than one patient who is bedridden, but they are able to make umbrellas. But of course, the point that you have told is well taken. We have to assess the patient. That's very important. So the education of children is another important area which we have to look. Okay, thank you. So I think we can wind up the session for today. Thank you, Dr. Pankaj. for being with us and having a wonderful class on palliative care emergencies.